Hey guys, welcome to Chapter 8. This is going to be Concepts of Care for Patients at the End of Life. The priority concept in this chapter is going to be comfort. Whenever we are providing end-of-life care, comfort is always going to be the top priority. The interrelated concepts in this chapter include cognition, perfusion, and ethics. Dying is a normal part of the human life cycle, but is often feared to be a time of pain and suffering. The dying process does not need to be physically painful for patients and emotionally agonizing for family members. Healthcare providers can guide patients and family members to decisions and services that will assist them to die with dignity and to die peacefully. The nurse has the biggest impact on the patient's experience with death, and we also help provide a peaceful death. A peaceful death is one that is free from avoidable distress and/or suffering. It is in agreement with patient and family wishes, and it is consistent with clinical standards. Take a moment to think about what you would consider to be aspects of dying with dignity. For some people, that may be no life-saving measures such as CPR, and to others, they may want their family around. What dying with dignity means is up to the patient. 8.1, and these are the leading causes of death in the United States in 2020. Death generally occurs after a long period of suffering from a chronic illness like the ones that are listed in this table. Of course, we all know you can die suddenly or you can die from an accident, but those aren't necessarily leading causes of death in the U.S. Death. Death is defined as the cessation of integrated tissue and organ function, as evidenced by lack of heartbeat, absence of respirations, or irreversible brain dysfunction. Direct causes of death include heart failure secondary to cardiac dysrhythmias, MI, or cardiac shock. It can also be respiratory failure secondary to pulmonary embolism, heart failure, pneumonia, lung disease, or respiratory arrest caused by increased intracranial pressure. The Patient Self-Determination Act was passed in 1991, and it granted Americans the right to determine the medical care that they wanted if they were to become incapacitated. Documentation is done by completing an advanced directive. Every patient should be asked if they have an advanced directive, and if they don't, they should be provided the opportunity to establish one. Durable power of attorney for healthcare, separate form of power of attorney of finances. This is a person who makes healthcare decisions for a patient once the physician deems them incapable of doing so for themselves. So I do want to once again reiterate that the durable power of attorney for healthcare is separate from the power of attorney for your patient's finances. For a living will, these are interventions one does or does not want if death is near. A DNR is a do not resuscitate in the event of cardiac or respiratory arrest, and CPR must be initiated if that DNR is not in place. Think about what items you might want to include in your living will. I know for one of my things, my husband and I, we discuss these matters because you need to have somebody in place who can make these decisions for you, and you need to have somebody who knows what you want. Just in case, we never expect to be in that opportunity. Your patients probably don't either, but if they're ever in the situation, it's always great to have these things. Palliative care. These are not the same thing. Hospice is for those with a prognosis of 6 months or less to live due to a terminal illness. Palliative care is different. Palliative care is for people with life-threatening diseases to manage symptoms and improve quality of life. For example, a COPD patient who is on continuous oxygen, that oxygen is helpful for improving and managing their symptoms for a chronic lifelong disease that they're going to have. On to our assessment. So signs and symptoms of impending death are going to include weakness, increased sleep, changes in breathing patterns. Often we'll see very shallow, rapid breaths with periods of apnea. These are called Cheyne-Stokes respirations. We may see coughing or gurgling. A lot of times, our patients who are at the end stages of life have a lot of trouble clearing secretions in the back of their throat, and that's what that sound is. Your patient may have cold, mottled skin, a decreased blood pressure, they may be incontinent, and they may have a decreased level of consciousness. Watch closely for signs of impaired comfort, especially in your patients who can't talk. You may see grimacing, moaning, and restlessness. Provide interventions to remedy the discomfort. An example would be to cover the patient with a blanket, use moist swabs to keep their mouth and their lips moist, administer medications to reduce secretions, change positioning, and keep the environment calming and let the patient know that food and drink is available. Don't force the patient to eat or drink. A lot of times, families will be distraught if they bring the patient's favorite food. They may have concerns that the patient isn't hungry, they're not eating, even though it's their favorite. Just reassure the family, let the patient know it's available, but in this stage, we really don't want to force them to eat. In addition to that, help the family show ways of loving and caring. In regards to a psychosocial assessment, people facing death can experience many emotions and have difficulty coping. Tailor your care to the patient's specific needs and values because everyone is different. We use the HOPE mnemonic to assess spirituality. H is for sources of hope and strength. O is for organized religion and the role that it plays in one's life. P is for personal spirituality, rituals, and practices. And E is for the effects of religion and spirituality on care and end-of-life decisions. Families also experience fear and anxiety when a loved one is at the end of life. Provide information on the dying process, interventions to control distress, and ask if they would like to speak to a bereavement counselor or a clergy member. Box 8.3 on page 146 details the emotional signs of approaching death. Saying goodbye is encouraged for both the patient and family members, and it can bring comfort to both parties. Let's analyze our cues and prioritize our hypothesis. The priority for patients at the end of life is managing symptoms of distress and promoting comfort for a peaceful death. For patient implementation, we want to be sure that the needs and preferences are acknowledged and met. We want to ensure that there is control or management of symptoms of distress. We want to ensure meaningful interactions with family and other loved ones, and we always do our very best to provide a peaceful death. These are the goals for patients nearing death, and this is accomplished through interprofessional collaboration. One of the major ways that we do this is through hospice care, and the big focus of that is based on quality of life. And a large part of the care plan is actually where the patient would like to die. Some patients prefer to die in their homes, and some patients actually do prefer to pass away while they are inpatient. They don't want to pass away at their own home. Moving on to of distress. First off, we have pain, and this is the most feared symptom. I will share a personal story. I did have a patient one time. She had been through an extensive battle with colon cancer, and her family was at the point where they were discussing hospice, and they just wanted me in the room with them. And my patient confided in me that she was just scared it was going to hurt. And that is what scared her the most. It wasn't even dying. It was that it was going to be painful when she did go, and she didn't want her family to see her like that. So these are things that we want to take into consideration. Patients should take a regimen that controlled their pain, but as death nears, they may lose their ability to swallow, meaning a different route may be necessary. Morphine sulfate is usually the opioid of choice to control pain. We want to do everything we can to minimize episodes of breakthrough pain at the end of life. Weakness. We want the patient to remain in bed to prevent falls and injuries. We want to make sure that they are in a comfortable hospital bed. They may not be able to sit up on their own, and those hospital beds are great for that. With just the push of a button, they can lift their legs, they can sit up and get comfortable. They may get a Foley catheter for comfort. This is one of the times that we can put in an indwelling catheter just for comfort measures. With dysphagia, offer food but don't force it, and ensure the family that anorexia is normal at this stage. and if necessary, you can moisten your patient's mouth and lips so they're comfortable. For breathlessness and dyspnea, perform assessments to determine the cause and precipitating factors. Pharmacologic interventions should be used early to reduce air hunger, anxiety, and pulmonary congestion. Opioids like morphine sulfate are the treatment of choice. Offer oxygen for comfort. Bronchodilators such as albuterol may be given for bronchospasms. You may know those more so as wheezing. Patients with fluid overload dyspnea may be given a diuretic. Antibiotics are given if dyspnea is related to an infection. So here you can see how we treat is based on what is causing it. Secretions can cause distress. Anticholinergics are administered by mouth to dry secretions, and suctioning is not recommended at the end of life. For nausea and vomiting, identify the cause. If it's caused by constipation, give a biphosphate enema, that is a fleet enema. You can also give antiemetic agents such as Zofran or Reglan. You can remove odors and keep the temperature at the patient's desired level. For agitation and delirium, assess for causes of agitation like urinary retention, pain or constipation, and medications. Give antipsychotics if necessary, but only give one at a time. You can also use music therapy, PET, and aromatherapy. And for seizures, seizure medications cannot be crushed, so patients who cannot swallow require around-the-clock benzodiazepines like lorazepam or diazepam. Sedation may be a side effect of drug therapy, and it may increase with time. There is no evidence that administering medications for symptoms of distress using established protocols hastens death. Nurses should follow guidelines to keep the patient comfortable. Patients may have refractory symptoms of distress that do not respond to treatment. Palliative sedation may be indicated by administering benzodiazepines, barbiturates, or short-acting anesthetics to decrease suffering. To meet psychosocial needs, assess the patient and family understanding of illness and that it is terminal. In grief, patients may suffer with the anticipated death and lose the ability to engage with others. In mourning, this is going to be the outward expression of grief. Mourning varies by culture and values. Box 8.4 on page 150 details some examples of this. Allow the family and patient to grieve and express their feelings. Be present for patients and families. Demonstrate empathy. Do not minimize their reactions. Have an optimistic attitude and provide privacy when you are giving care. Allow the patient to conduct a life review through storytelling and reminiscing on their life. And lastly, identify spiritual needs and inquire if they would like counseling or to meet with clergy members. Postmortem care. If the death was in home and expected, 911 should not be called. Call the medical examiner if the death was unexpected or suspicious. If death occurs within 24 hours of admission, some facilities will still have you call the medical examiner regardless. Determine your facility's procedure for pronouncing death. Allow family to stay with the patient and participate in postmortem care if they would like to. Follow your facility's procedure for preparing and transferring. And box 8.8 on page 153 has the details for postmortem care. At the end of life, when we are evaluating our outcomes for our nursing interventions, just keep in mind that a peaceful death is always the ultimate goal. Active euthanasia implies that the healthcare provider takes action that purposefully causes the patient's death. Even with the patient's permission, this is not supported or illegal in the United States. We also have physician-assisted death, aka medical aid in dying. This is legal in some European countries and 11 states for terminally ill patients. Think about what your thoughts are on your physician-assisted deaths and voluntary active euthanasia. You can think about the legal implications for this, think about the ethical implications, and do you think that we have a right to determine this? Is this really the patient's right, or is it just morally wrong? We look at our withdrawing or withholding care involves discontinuing therapies that might prolong life, like letting the patient die naturally. Validate the family's concerns and inform them that withdrawing care is not what causes deaths. It is the progression of a patient's disease. It's the disease that causes the death. We're just not preventing it at that point. And then we have voluntary stopping eating and drinking. This is another method to speed up the dying process, but patients want to feel in control over their death, and that may be why they do this, because they feel like they have some sort of control here.